Hi, my name is Alina, and I'm going to be teaching you a little bit about cardiomyopathies today. So basically, a cardiomyopathy is a diverse group of diseases that affects primarily the heart muscle. Most of them are due to remodeling from the neurohumoral responses to things like low blood supply to the heart or high blood pressure on the heart muscle. They may be secondary conditions after experiencing symptoms such as infectious disease, exposure to toxins, things like that. For most cardiomyopathies, the cause is unknown, but they could be from things like hypertension, alcohol and drug use, etc. So there's three different classifications. There's dilated, which in dilated, the ventricles are enlarged, which makes sense because it's dilated. In hypertrophic cardiomyopathies, there are thickened and stiffened walls, so the intraventricular septum is thicker. And then in restrictive cardiomyopathies, the walls are stiffened but not necessarily thicker. So testing for cardiomyopathies depends on the specific type, but you have your typical EKG, your echocardiogram, your chest x-rays, and your serum BNP levels, which BNP stands for B-type natriuretic peptide, which those levels will be higher if you're experiencing heart failure. So those are the basic forms of cardiomyopathies. Now to focus on specific ones, your dilated cardiomyopathies, your ventricles are dilated. And so causes, you can see here, include things like ischemic heart disease and valvular disease, etc. Basically, what happens is the systolic function isn't working correctly, which leads to an increase of volume in the blood in the heart and ventricular dilation and systolic heart failure. Signs and symptoms include dyspnea, fatigue, and pedal edema. And pedal edema is actually pretty similar to something I have, which is lymphedema. And they kind of both look like this. This is kind of what your feet might look like, a little bit more swollen. So that's the idea behind pedal edema. Continuing on, we have, upon examination of a dilated cardiomyopathy, you might find the pulse at the apex of the heart displaced. You might find a third heart sound, the swelling of body parts like your lower legs, a bulging external jugular vein, or congestion in the lungs. Testing includes a chest x-ray and an echocardiogram, and as far as management, we want to reduce the blood volume and increase the contractility. We also want to reverse the underlying disorder. So underlying disorders include things such as these causes listed here, like diabetes, renal failure, alcohol or drug toxicity, and so on. And in severe cases, we might actually revert to a heart transplant. As far as hypertrophic cardiomyopathies go, the intraventricular septum right here becomes thickened, and increased back pressure from the left ventricle causes the left atria to dilate as well. The two major categories of these are hypertrophic obstructive cardiomyopathies, also called asymmetric septal hypertrophic cardiomyopathy or subaortic stenosis, which a subaortic stenosis is the narrowing of the left ventricle of the heart below the aortic valve. This is the most commonly inherited cardiac disorder, and it may cause the outflow obstruction to the left ventricle outflow tract when the heart rate is increased and when intravascular volume is decreased. This is a significant risk factor for serious ventricular dysrhythmias and sudden death, so this is something you definitely don't want. The other category is a hypertensive or valvular hypertrophic cardiomyopathy, which occurs from increased resistance to ventricular ejection. And so basically what happens is your myocytes go through hypertrophy to compensate for this, and this leads to their long-term dysfunction, which then leads to systolic dysfunction of the ventricle. It may be asymptomatic, or people with this condition may complain of angina, syncope, dyspnea on exertion, or palpitations. Upon examination, you will find extra heart sounds and murmurs, and testing can be done with an echocardiography and cardiac catheterization. For your restrictive cardiomyopathies, the ventricle walls are restricted from expanding, which causes them to be stiff. And this tends to be over the entire heart, so both the atria become dilated as well, which is hard to see in this picture. They can have fibrotic tissue, protein deposition, or iron excess in the heart muscle, but either way, it's got the same effect where it doesn't let the heart expand as it should. So basically what happens is the filling of the ventricles is restricted and diastolic pressure is increased in either or both ventricles. The cause may be unknown, but it may be due to systemic diseases manifesting in the heart, such as these listed right here. The myocardium becomes rigid and non-compliant, and it may be confused with constrictive pericarditis. So just a brief overview, as we see here, this is your dilated with enlarged ventricles, hypertrophic with thickened intraventricular septum, and your restrictive with stiffened walls. These are my references right here to the information that I have on the PowerPoint. And if you have any other questions, just let me know. Thank you, and I hope you learned a bit more about cardiomyopathy.